Alrighty, we're going to get started. Welcome to our webinar today, the Don't Let Hep B Win webinar. My name is Naomi Louie, and I am the program manager for the Chronic and Infectious Disease Prevention Programs at the Center for Asian Health Equity at the University of Chicago Medicine, and I will be moderating today's webinar. We are so glad to have you all here today to learn more about hepatitis B. Now a bit about our organization. The Center for Asian Health Equity, or CAHE, is a partnership between the University of Chicago and the Asian Health Coalition. And with the assets of both the research institution and the respected nonprofit, we work to investigate health disparities that disproportionately affect particularly Asian and African immigrant populations. To address these health disparities, we work collaboratively with community-based organizations that serve these populations to develop and implement culturally and linguistically appropriate health programs and initiatives. So specifically, our hepatitis B programs, which launched back in 2013, focuses on multiple aspects. So on the community side, we work with community leaders and organizations to conduct outreach and educate the community about hepatitis B. And we work with them and with clinics across the city of Chicago to screen community members for Hep B, making sure that they're linked to further care if they screen positive for Hep B or if they need to get vaccinated. And all of these efforts have been funded by the Illinois Department of Public Health, the Office of Minority Health, and the Gilead Foundation. So just a few reminders before we get started. This webinar is being recorded and will be posted to our Asian Health Equity YouTube channel. And that link will be shared with you after this webinar and after we get that all sorted out. So you can feel free to go back and listen to the webinar and share it with your colleagues later on. We also have the Q&A section of the webinar set up, so feel free to submit your questions there. And if time allows, at the end of the webinar, we will ask a few questions and get those answered. Otherwise, any questions that you submit or any questions that you email to us at hbvinfo@asianhealth.org, all of those answers will be sent along with our follow-up email after this webinar. So momentarily, we are going to have an anonymous poll come up. And I know many of you are here to learn more about hepatitis B, but we'd love to kind of get you started with jogging those brains a little bit. So do your best on these questions, and we will close it in a few seconds. So just do your best. Alrighty, a few more seconds on that poll so we can get everybody's vote in. And this is anonymous, we're not testing you in any way. Alrighty. And I'm gonna share the results with all of you so you can kind of see where everyone is at. As for the populations at high risk for HBV, Dr. Paul is going to talk more about that. So you'll hear more on that. And for question number 2, for vaccination, so the HBV vaccine has been around for about 40 years, and only about 25% of the adult population in the US has been vaccinated for HBV. So I know when I saw those numbers, it seemed a little low to me, so I was surprised. But I think this just goes to show how much work remains to be done around hepatitis B. So thanks for joining us with that poll. I know we're so thankful to have Dr. Sonali Paul with us today to talk about hepatitis B. And Dr. Paul is an assistant professor of medicine at the University of Chicago Medicine and the liver transplant specialist at the Center for Liver Diseases at the University of Chicago Medicine. And as a hepatologist, Dr. Paul specializes in the care of patients with liver disease with a particular interest in hepatitis B, autoimmune and cholestatic liver diseases, and liver transplantation. She is also an active researcher with a focus on evidence-based medicine and patient-centered outcomes. So thank you so much for your time today, Dr. Paul, and you can take it away.
Great, thank you so much for having me. So I'm gonna see if I can share my screen now. Can everyone, looks okay?
Yep, we can see that. Thanks, Dr. Paul.
So thank you so much for having me. I'm very excited to be here. So today I'm going to be talking about really the basics of hepatitis B. So hepatitis B 101, and then we'll spend a good amount of time talking about cultural humility. So in terms of the Hep B, we'll talk about the epidemiology. We'll talk about risk factors and screening. We'll talk about serology and diagnosis. The hepatitis B serology is, even to me, I'm 6 years out of fellowship training, is still sometimes tricky. We'll talk about treatment, and then we'll talk about how to have culturally appropriate conversations. And then we'll touch on cultural competency, but then also humility. So the hepatitis B virus, it's the only DNA virus, and this is why it is so incredibly hard to cure. Unlike hepatitis C, which is an RNA virus, we now have cures for that. Hepatitis B is incredibly smart. And so what it does is integrates into the liver cells, and it's pretty much there. And we haven't figured out a way to make it go away, even if they're, even if they're not actively infectious. There are a lot of serotypes and genotypes. They're not terribly important when it comes to the management of hepatitis B. It's unlike hepatitis C. There are different types, but we don't really think about that in clinical practice. So the complications of hepatitis B. So one is cirrhosis or chronic liver disease. So this is a slide actually I think is looking at Hep C, but the same can be said with hepatitis B. So here you can see the liver, there's some fibrosis, and then here kind of the end stage liver disease is cirrhosis. And then anyone that has cirrhosis is also at risk for hepatocellular carcinoma. But what's interesting about hepatitis B is that this is one of the only diseases that can independently cause hepatocellular carcinoma or liver cancer in those without cirrhosis. So really important to screen patients with Hep B for liver cancer, which we'll talk about. So in terms of the prevalence, you can see that in the United States here, the prevalence is really intermediate, so 2 to 7%, so not very high. But in places like South America and Africa, Asia, Eastern European populations, much, much higher, so greater than 8%. So unlike hepatitis C, which was the big focus in the States for research and cure, I think Hep B is was not in the forefront, but I think now that we have cured Hep C, I'm hoping that more of that research will go towards hepatitis B. So Hep B is a great example of how vaccines really do work. And so if you look at, this looks at the estimated incidence of acute Hep B infection in the US. And so in the 80s, we kind of knew about Hep B. The vaccine was licensed in 1980. We started actually screening pregnant women in the late 80s, which was really, really important because vertical transmission, which we'll talk about, is one of the most common ways people can get hepatitis B. And then if you were born in the early 90s, we started routinely immunizing infants. And so, and then in like the late 90s, we started doing it for routine adolescents. And so for all of us in healthcare, we all have to get our hepatitis B vaccines and checked for antibody response. So you can see as the vaccines came out, the incidence of acute Hep B greatly decreased in the US. So in terms of risk factors, it's a blood-borne disease. So anything that's blood-to-blood transmission, sexual contacts as well, people who inject drugs or PWID, men who have sex with men, and then really household contacts too, if in that context. But as we talked about, vertical transmission is really one of the most important ways and preventable ways that people can get hepatitis B. So if the mom has hepatitis B, she can pass it on to the baby in utero. So, and we'll talk about why that's important and how we can prevent that. So I'm a little biased in terms of who I screen for hepatitis B because I'm a liver doctor. And so anyone that comes to see me invariably has abnormal liver tests or some reason to screen for hepatitis B. So I screen everybody independent of their risk factors. But for primary care population, sometimes it's not cost effective to do that. So if you're seeing a patient and you're a primary care doctor, or you're thinking about hepatitis B for another reason, these are the folks that you should be screening for. So those that live in endemic areas, so we kind of talked about Asia, Africa, Eastern European, people who inject drugs, men who have sex with men, sexual partners of patients with hepatitis B, anyone that has hepatitis C or HIVs, really important. So hepatitis C, if someone has hepatitis B with it, if you treat their hepatitis C, the hepatitis B becomes the dominant virus and can reactivate, and that can be pretty deadly if it's not treated. And then those folks with HIV as well should get tested because a lot of the treatments for HIV and Hep B are together. And then anyone that gets hemodialysis, so our dialysis centers are really good at screening patients for hepatitis B. And then pregnant individuals, almost all OBs are extremely good at screening their pregnant folks. In the new recommendations actually also recommend screening for hepatitis C as well in pregnancy. And then anyone that's going to get immunosuppressive therapy. So if you're going to suppress someone's immune system, really important to know if they have hepatitis B, because as we kind of I alluded to in the beginning, the virus integrates into the hepatocytes and can reactivate. So what tests do we order? So the most important one is the surface antigen, because we want to know because that tells us if the person is infectious. There's a core antibody and then also a surface antibody, which we'll talk about. So the surface antigen really kind of is the hallmark of acute or chronic infection. So if you see a positive surface antigen, they definitely have hepatitis B. There's an IgM core antibody. So IgM, if you think about your immunology days, IgM is always the kind of acute phase. So if it's an acute infection, they may not even have their surface antigen yet, but they might be able to have an IgM core antibody. So you can tell that there's an acute infection. There's an IgG core antibody. So this tells us whether there's been an infection either in the past or in the present. So if you're currently infected and you have positive surface antigen, that means that you have chronic infection. But if your surface antigen is negative, but your core is positive, core IgG is positive, that means at some point in your life you had hepatitis B, but your body kind of cleared it. And then the surface antibody is what we all want and confers immunity. So there's also, for those that kind of know, there's an E antigen and E antibody, which are incredibly confusing. It's a marker of infectivity, and we're not really going to go over this, and I can certainly answer questions about it later, but there are kind of these other two serologies that make, I think, Hep B very confusing in general. But for our purposes, kind of looking at it, we can kind of go through a few different types of states. So if everything is negative, so here you have your surface antigen, your total or your IgG anti-core antibody, there's the IgM, and then you have your surface antibody. So if everything is negative, you've never been infected, and there's no evidence of immunization. So here, if your surface antigen is positive and your total anti-core is positive, or your IgG, but the IgM is negative and you don't have antibodies, this indicates a chronic infection. And here, similar to the previous, these two are positive, the surface antigen and the total anti-core antibody, or the IgG. And here, the IgM is also positive. So this shows us that you have an acute infection. And then this is kind of the one I was talking about, where your surface antigen is negative, your IgM is negative, but your total or IgG is positive, and you have an antibody. So at some point in this person's life, they had hepatitis B, but their body cleared it, and they're left with antibody. Not everyone makes an antibody response to it, but and the antibody response can wane over time, but it's important to know. And then one thing I say is that I never say the patient is immune, because as we kind of talked about, hepatitis B can reactivate. It's never actually fully gone from the liver. So they're never fully immune. They just have cleared the virus. And then here, if everything is negative except for your surface antibody, that indicates immunity, usually after immunization. So here we have acute infection. The patient's surface antigen is positive. Their DNA, their HBV DNA is really high in the blood. Eventually, over time, the surface antigen will wean. They'll develop an antibody response, and then their total core or IgG antibody will be positive. And then here you can see that the IgM starts waning as well. Oops. Here we have chronic infection. So similarly, there's a surface antigen that kind of just is persistent. And here you have the total IgG or total core antibody. Surface antigen is persistent. They may or may not have DNA with them. And then there's no core IgM. And this is kind of how chronic infection looks like. So what's really important is the risk of chronic infection. And so if someone gets hepatitis B as an adult, and I've actually seen now several people, like in the last few months, I don't know why, with acute hepatitis B. Adults have robust immune systems. And so typically within 6 months, they're able to kind of clear the virus usually without even medications. Their immune system can kind of just clear it and they'll develop a surface antibody. Unfortunately, though, with neonates and children, the risk of chronic infection is much, much higher, almost 100%. So this is why vertical transmission is so important, because now we have, if the mom has it, then the baby is most certainly going to get it unless something is done to prevent it, which we'll talk about. So in terms of screening, so we talked about kind of who should get screened for hepatitis B, but this is also talking about if you have someone with hepatitis B who needs liver cancer screening. So as I mentioned before, this is one of the diseases that you don't actually have to have cirrhosis to have liver cancer. So these patients require lifelong liver cancer screening, even without cirrhosis. And so the guidelines will actually say, if you're a hepatitis B carrier, if you're an Asian male greater than 40, an Asian female greater than 50, all patients with cirrhosis and hepatitis B, if you have a family history of liver cancer, and Africans over the age of 20. So these are what the formal guidelines will say in terms of who needs to be screened for liver cancer. Having said that, though, I am entirely very cautious, and I screen all of my patients every 6 months with some sort of imaging test and a blood test, because liver cancer, if treated early, is very preventable. Not preventable, it's very treatable if caught early. And the other thing I'll say is this point of Africans over the age of 20, so incredibly important. Because there's a genotype that is more common in Africa that increases the risk of liver cancer exponentially. And so I've seen, 20-year-olds, I've had patients die of mine that are 25, 30 with metastatic liver cancer because no one really ever checked. And even if they caught it early, it just tends to be a lot more aggressive. So definitely screening folks like those. So what do we order? So there's an imaging test, so an ultrasound or some sort of cross-sectional imaging with a CAT scan or an MRI. I personally prefer MRIs or CAT scans, mainly because ultrasounds are like those old Polaroid pictures that kind of pop out right then and there. You have the image. You can kind of see all the detail. You can kind of see the big picture, but you can't see all the details. The CT and MRIs are like the iPhone 10 or 12s or whatever number we're on. The clarity is just much better. And so, and you can catch lesions much earlier. There's also a blood test, an alpha fetoprotein or an AFP that you can also order. So this is what's done every 6 months. This is a very busy slide, but we're not going to really go into it. But this is why I want to kind of just say that there are many different stages of hepatitis B. There's immunotolerant, immunoactive, inactive carrier, and resolution. And this is kind of the treatment algorithm that we go through. But just looking at that slide, if you look at this slide for treatment of hepatitis B compared to treatment of hepatitis C, you can clearly see that Hep B is much more complicated. And so, so it's a very tricky and smart virus. Okay, so in terms of when we want to treat someone for hepatitis B, so the holy grail of therapy is to lose their surface antigen. We want that surface antigen gone. but unfortunately it only happens 3 to 5% of the time. So it's not very common if you're going to start someone on treatment that they're going to lose their surface antigen. Not to go back to the E antigen, but if your patient is E antigen, which some patients are, if they're positive for E antigen, then we want their E antigen to convert to negative and then to form E antibodies, so some sort of protection. That's kind of the secondary endpoint that we look at. And then there are E antigen negative patients who require lifelong therapy. So in terms of treatment options, there are nucleotide analogs. So the older ones that really aren't used anymore are lamivudine, talbivudine, and the There was a lot of resistance with these medications, and so people would take it, and then the virus would mutate because it's so smart, and it would no longer be effective. So this has really fallen out of favor. No one uses this anymore. And really, entecavir is now the preferred first line if they've never been exposed to lamivudine or any of those other medicines. You can give them entecavir, and if they take it every day and and they don't miss any doses, usually you can control their virus. I've had a few patients where entecavir didn't do it, and I didn't question their compliance. And I knew they were taking their medicine, but for whatever reason, the entecavir wasn't working as well. And so in those cases, you can switch to tenofovir. If entecavir resistance is incredibly rare, but just in case. And then if they've had lamivudine, tenofovir is the better medicine. And then in cases of pregnancy, if you want to treat their hepatitis B during pregnancy, tenofovir is used. And I don't actually think there's been any reports of tenofovir resistance. So it's a really great drug. And then talking about hepatitis B and pregnancy. So the guidelines are a little kind of iffy on this. Really, we say we only want to treat if the viral load is very, very high, so greater than 200,000. And we would start in the third trimester, and tenofovir is preferred. Talbivudine can also be used. I have to say, though, I mean, if I had hepatitis B and I was pregnant and I had a positive viral load, I'd want to get myself on treatment, mainly because we know that if the lower the viral load going into labor and delivery, the lower risk of transmission to the baby. So you really want to get that viral load down. But most importantly, the baby, after the baby's born, needs the hepatitis B vaccine at birth. And hepatitis B immunoglobulin. So really, really important. And this is how we prevent vertical transmission. If this happens, the baby is almost always never gets chronic hepatitis B. So from my perspective, when I say a woman who's pregnant with Hep B, the onus I really find is on me to communicate that to not only the OB team, but also to the pediatricians team. And so I usually write a note out that they keep in their overnight bag or whatever bag that they're going to bring, that they give to whoever's taking care of them, just because it is so important that the baby get those two things. And so we kind of talked about this, but once exposed to hepatitis B, you'll always have it in your system, in the liver cells. And so it gets integrated into it, even if the virus is cleared. And so you can see here in chronic or quote unquote resolved hepatitis B infection, there's still hepatocytes kind of live, or rather DNA particles living in the liver cells. So what happens when you suppress the immune system? The immune system in a healthy person, they're actually controlling those little, even if it's 5 or 6 particles, it's under control. You take away the immune system's response to be able to do that, and then you get reactivation. So this is actually a really important point in terms of when patients are getting chemotherapy. And so it's really important for oncology, and specifically when patients get rituximab. So rituximab's for cancer therapy, but it's also used for a lot of other treatments. So really important to kind of disseminate this information to the other specialties. And I think people have done, I think we're getting better at screening patients for hepatitis B when we're going to use immunosuppression. So in terms of reactivation, so we talked about how it increases hepatitis B replication. So that can result in hepatitis B flares, liver failure, or death. And it can also interrupt or delay treatment. And reactivation really depends. It's variable, so 15 to 80%. I did my fellowship at Tufts Medical Center in Boston, where it was in the middle of Chinatown. And so we saw a ton of hepatitis B. And at that point, we didn't know as much about reactivation. And so I definitely saw my fair share of folks die from fulminant liver failure because their hepatitis B reactivated in the setting of their chemotherapy regimen. But the good news is that appropriate prophylaxis is effective and available. So anything, you can even potentially even use lamivudine in this situation, and which really lowers the reactivation rate to almost nothing. Okay, so we're gonna kind of stop there. So that's kind of the basics of hepatitis B. I'm going to shift to kind of cultural competency and cultural humility. And so there was an article in the New York Times. Pauline Chen is a surgeon. She actually wrote an amazing book about, it's called Final Exam, and it's just kind of her navigation through the medical world and training. I highly recommend it. But there was this article called Bridging the Culture Gap, which I'll kind of focus and go back to. So just kind of defining what culture is, right? So that it's a body of learned beliefs, traditions, principles, and guides for behavior that are commonly shared among members of a particular group. So it serves as a roadmap for both perceiving and interacting with the world. And so what is ethnicity? And so that refers to a particular social groups and complex societies, groups differentiated not only on the basis of their shared cultural content, but also on the basis of social attitudes and economic and political considerations. So why is culture important in healthcare? I mean, it may seem obvious, but culture really influences powerful determinants of health-related behavior, which we'll talk about. And so not knowing about one's culture or the sensitivity to their health beliefs of different cultures can limit the ability to provide quality healthcare. So going back to this story, so I'm going to read a few of the snippets from the article. So this is Dr. Chen writing this. So one afternoon, not long after I finished my training, two sisters, both well-respected professionals in their late 40s, came to the hospital clinic. Both sisters had hepatitis B, and the older sister, like a fair number of chronic hepatitis B patients, had developed liver cancer. She and her sister were hoping that we might be able to remove the tumor. I remember watching the sisters' faces turn grim as the younger of the two drew a family tree on the flimsy paper covering the examining table. Under each branch, she wrote out the names of siblings and parents, and I shuddered over the number of LCs, her abbreviation for liver cancer, the sister scrawled next to a name. And so the context to this is that the two sisters, there were 6 children. The parents immigrated from China. The mom actually died of inoperable liver cancer. And several years after that, the 2 brothers were diagnosed with liver cancer and subsequently died. And it was only then where the remaining siblings looked into the family records and realized that the brothers had hepatitis B, and that's where this cancer came from. And most likely the mom had it too. And so all of the siblings got tested and all of them turned out to have chronic hepatitis B. And so she goes on to say, it would turn out that the older sister's cancer was small enough to remove surgically. And a year after her operation, I ran into one of the liver specialists I'd referred the family to for regular follow-up. The siblings he cared for, I learned, were faring well. But what a pity, my colleague said, shaking his head. If only one of the clinicians they had seen earlier had been a little more aware of some of the health concerns of Asian Americans. And so what he is alluding to is that if someone, if you have an Asian American patient or someone from Asia, screening for hepatitis B is really important, but also when the mom was diagnosed, and most likely they found, I would assume that they would have found the hepatitis B. The one thing that I ask all my patients to do is get all of their family members screened. And so this is kind of, if they had done that, maybe some of those deaths would have been preventable. So we talk a lot about cultural competency. So it's the patient's cultural background that influences their healthcare, their health disparities, their outcomes, communication and interactions, the doctor-patient relationship, and the experience of illness. So we talk a lot about cultural competency. And so what is the definition? So it's the knowledge and interpersonal skills that allow providers to understand, appreciate, and work with individuals from cultures other than their own. But it also involves an awareness and acceptance of cultural differences, a self-awareness, knowledge of the patient's culture, and adaptation of skills. And this is all to effectively deliver healthcare services. So cultural competency, I mean, not only, it's patient perceptions of quality of care, which gives them a sense of hope. So communication is not just about language or interpreters, it's also about being cognizant of what patients bring with them. Unfortunately, though, as you go further along in your career, you realize that there are a lot of time constraints, and there's a lot that's wrong with the system of medicine. I mean, I get 15 minutes to see my complex patients with liver disease, and while I try to provide culturally competent care, I'm sure I fail often, mainly because of the time constraints. But when I'm because I'm self-aware, I know that it's happening. And so the next time when I see that same patient, I can try and change it. So we know that cultural competence is linked to patient satisfaction. So this is looking at proportion of people who believe they would receive better healthcare if they were of different race and/or ethnicity. And so you can see that racial and ethnic minorities are less satisfied with the healthcare they receive. And just one kind of aside in terms of cultural competency, another really good book that I read actually in undergrad was The Spirit Catches You and You Fall Down. It's by Anne Fadiman. And it's an amazing story about this immigrant family, their Hmong family. And it was the daughter had a really rare form of epilepsy. And it's basically chronicles their navigation through the healthcare system and how their own cultural beliefs of what was happening and what was good for their daughter were so very different than what modern medicine was trying to do to their daughter. So I highly encourage reading this book at some point, just because it's really, one, fascinating, and two, made me realize how much of this is kind of integrated into society and how much it matters in terms of what we do in medicine. So how do we do this? How do we provide more culturally competent care? So it's not so much about requiring having a lot of information. It's not that I need to know everything about the culture, but really it's about the increased awareness. And so it's the cultural context of patients as well as doctors, and awareness in a self-critical way. And knowing that I'm also bringing my own cultural orientations to the relationship. And so it goes both ways. And I think the other really important thing is that, especially through training, and then, I think medical schools and healthcare systems were trying to be better about this, but I don't think we're quite there yet. But we in medicine, we focus on detection and treatment of disease. We don't really focus on what that experience of illness is like for the patient. And so it's not that we're insensitive. We're all compassionate people. That's why we're in healthcare. But we're trained to learn about the disease process, not the experience of being ill. And so if we treat the disease, so we think that if we treat the disease, the experience of illness will disappear, which may be true, but that whole process, is very traumatizing, can be very traumatizing to the patient. And so not realizing that experience of what they're going through and how they're experiencing healthcare through their eyes is really important. And then also cultural competence can be limiting. I mean, if people keep talking about it, it can really stop conversations and just be something, quote unquote, that's annoying, that becomes this thing that I have to check a box. So we never want it to feel like that. But culture is really fluid, and it's important for patients and doctors. And so knowing that, things change, and we'll get to this with cultural humility, but knowing that things change and being adaptable to that is really important. And culture sometimes isn't always important. If I'm seeing someone for, I don't know, influenza or something, they have an upper respiratory infection or an ear infection, and they need antibiotics, culture probably doesn't manifest in there as much as it would for something else. So showing an interest and affirming the person as an individual, not just having a checklist. It's not, going into an interaction when you see an Asian American patient and knowing the top 5 things that you need to ask, that's not entirely helpful versus knowing the person as an individual. And then there's this concept of cultural humility, which really hasn't been, well, there was a paper recently talking about cultural humility in a medical journal. This is really kind of from social worker, psychology perspective, but I think it's really important to talk not only about cultural competence, but humility. So this is the ability to maintain an interpersonal stance that is other-oriented or open to the other in relation to aspects of cultural identity that are most important to the person. So this is really having self-humility. I mean, I can learn things, but I do not and cannot know everything, but I want to learn more. And so this is one, things when I go into a patient room and I say something that clearly has offended them or is very offensive, not me not knowing, that's when I stop, I apologize, and I ask how I can make it better. And having that sense of humility is not something that is taught in medical school or in kind of medicine in general. So this is one example. I mean, the way you say things matters. So saying you're Japanese, you must love sushi versus you're Japanese, how do you feel about sushi? Not the best example. I couldn't find the best example of cultural humility, but one example. And so this is kind of the model of the 5 R's of cultural humility. And so in the middle, there's reflection, respect, regard, relevance, and resiliency. And then the outer circles look at feeling, doing, and thinking. And so kind of just dissecting each one of these. So reflection, so the aim of that is one will approach every encounter with humility and understanding that there is always something to learn from everyone. And so, reflecting on the encounter, what did I learn from each person in that encounter? And then respect, so one will treat every person with the utmost respect and strive to preserve dignity and respect. And then thinking back on the encounter, did I, treat everyone in that encounter respectfully? And the respect is something I often reflect on because, again, clinic gets busy, hospital inpatients, and our service sometimes gets crazy. We have 30 patients, we're trying to round. And, the patient only sees their doctor, especially in the inpatient side, for just that time in the morning. And so really respecting that time and respecting their time and making sure that they're getting all their questions answered is really important. And so regard, so one will hold every person in their highest regard while being aware of and not allowing unconscious biases to interfere in any interactions. And so unconscious bias or implicit bias is really another important kind of concept when it comes to this as well. And then relevance. So one will expect cultural humility to be relevant and apply this practice to every encounter. And so knowing whether the culture is relevant or not. And then resiliency. So one will embody the practice of cultural humility to enhance personal resilience and global compassion. So, so that's another thing, kind of thinking about cultural humility. So, so kind of concluding, so hepatitis B is a DNA virus. If anything, it's the trickiest virus and incredibly hard to cure, which we still don't have a cure for. And it can lead to cirrhosis and liver cancer. And screening is incredibly important, but knowing that cultural competency and humility are equally important. And that's all I have. I can take any questions. I'm going to stop sharing my screen for now.
Thank you so much, Dr. Paul. If you have any questions, feel free to pop them in the Q&A or in the chat box, and we'll be happy to answer those questions. And you can, of course, always email us later on at hbbinfo@asianhealth.org. So just a question for you, Dr. Paul. If you could elaborate maybe a little bit more on HBV screenings or liver cancer screenings. So you'd mentioned CT and MRI scans, as well as ultrasounds. What are your thoughts on Fibro scans?
Yeah, so it's a good question. So FibroScan tells us how stiff the liver is. So it's a good way to know if someone has cirrhosis or not. So in all of my patients that have hepatitis B, we will check a FibroScan annually if they don't have cirrhosis, just to know if they're kind of progressing. But it's more, it doesn't tell us as much about the liver parenchyma or how the liver looks. And so that's where ultrasound or some sort of other imaging modality is more helpful.
Great, thank you. We have another question in the Q&A box. Is hepatitis B screening part of standard blood work done during an annual checkup? If not, is there a reason why?
So it isn't, and it's a great question. So if you go to well, I'll preface it with, if you go to a hepatologist for your annual physical, you'll get hepatitis B screening because that's what we do. In primary care practice, I mean, it's not done routinely unless the primary care doctor is very attuned to the risk factors. And so if you're from an endemic area or you have any of the risk factors we talked about, then they will potentially, they should screen. But again, things get very busy in clinical practice, and it's not always what you're thinking about as like of all of the things you have to think about in primary care. So it will often get missed. There's no, it probably comes down to cost in terms of why we don't screen everybody for hepatitis B and make sure that they were vaccinated. But I do that in my own practice.
Great, thank you. And one on vaccination, is it sufficient to get one vaccination series in a lifetime?
So as long as your antibody titers don't wane, it's a great question. So there are people who get vaccinated and for whatever reason cannot generate the surface antibody. And it's especially kind of distressing if you're in healthcare. So I have a lot of people, like physicians or nurse practitioners, come to me and say, listen, I got the vaccine series like 5 times and I still can't get the antibody response. And it does happen. And you can try a few more times and then it's kind of, just there are some people that won't generate the response. But if your antibody is still there, there's no kind of booster that we've thought about for hepatitis B. So typically once your antibody is positive, it should stay positive. And there is a new Hep B vaccine series. It used to be, it was a little cumbersome. So it was you get the vaccine and then a month later you get another one, and then a month later you get, 6 months later you get the last one. So it was a 3-part series. There is a new vaccine series that's 2 parts and much better in terms of the antibody response.
Great, thank you. And since we do have a lot of students on this webinar, what advice do you have for students who might want to become more involved in hepatitis advocacy within their communities or in their own families?
Yeah, so I mean, I think, certainly within my family, I mean, I've tried to figure out everyone's hepatitis B vaccination status. I had a patient who came to me, she was Asian American, and she was pregnant and discovered that she had hepatitis B. And so we were talking and she was like, I have no idea how I got this. And I was like, oh, you should ask your parents. Like, have your parents been tested, right? And it turns out that both of our parents had hepatitis B, but no one had talked about it. And so no one got screened. And so, I think just having kind of open kind of conversations. In terms of what you can do, the American Liver Foundation is a great organization too, that really is about advocacy. So there's a lot of things about, it talks about transplant, but there's ways to get involved in community fundraisers, things like that.
Great, thanks. And another question from an attendee, is it safe to get vaccinated with more than one series? Sometimes immigrants do not have a record, so they need to do it again for immigration purposes or healthcare jobs.
Yes, it's safe. There's nothing, I mean, if their antibodies are already positive, then getting another vaccine series isn't going to be particularly helpful, but it's not going to be harmful.
Great, thank you. And for those that are students on this call, what does the path to becoming a hepatologist look like?
Very long. It's a good question. So so it's 4 years of med school, and then 3 years of internal medicine residency. And then unfortunately, you still have to do a GI fellowship, a gastroenterology fellowship, in order to become a hepatologist. And so I knew early on in med school, because I had a lot of interactions with liver patients, I knew this is what I wanted to do. So for me, going into a 3-year GI fellowship was kind of a stepping stone to get to my hepatology fellowship. And so it's basically 4 years of med school and then 7, and then it's another extra year of training. So 7 of kind of postgraduate training. Having said that, though, there is a new program that the ASLD, which is our American Association for the Study of Liver Diseases, our main society has come out with, where it's we called it a pilot program, but it's actually pretty commonplace now, where you can actually combine your GI fellowship. You can do 2 years of GI training, and then that third year, it can be your transplant year. So at least it would decrease 1 year of training. And it's increasing. I think the number of people that are going into hepatology now are increasing, which is good.
Great, thank you, Dr. Paul. And we're going to wrap up the questions there. A recording of this webinar is going to be made available on our YouTube channel shortly, and we will also send out a PDF of the slides from today's webinar to all of you who have attended. And as I continue to mention, you can always send us questions about hepatitis B to hbvinfo@asianhealth.org. And as you may or may not know, this month is Hepatitis Awareness Month, and it's Asian American Pacific Islander Heritage Month. And so we're thankful that you all were able to come and join us in celebrating and recognizing this great month of May. And with that, we'll give you 14 minutes back on this hour of the webinar. Thank you so much for joining us, and we hope you have a good rest of your day.